All right, so let's go ahead and get started. I'll start by introducing Dr. Schluger, and then he'll pull up his slides and share that with us. So Dr. Neil Schluger is the Barbara and William Rosenthal Chair of the Department of Medicine at New York Medical College and Director of Medicine at Westchester Medical Center in Valhalla, New York. He's also the Associate Dean for Clinical and Translational Research in the School of Medicine. So in addition to his academic, administrative, and clinical responsibilities, he's in his current roles, he focuses on public health challenges such as TB, tobacco use, air pollution, and global aspects of lung health. He's also, been a principal investigator on the TB Clinical Trials Consortium, which is an international collaboration through the CDC for 25 years. And he was chair of that consortium for 16 years, actually. A lot of the research started during his time and tenure there are actually being translated now into clinical practice. And just has a wealth of knowledge and experience about TB and other global aspects of just lung health in general, both in the US and globally. So welcome, Neil, and I'll turn it over to you.
Great, thanks very much, Anita, and I apologize again, everybody, for being late. What I'm going to try to do today is give you an overview of tuberculosis epidemiology, first at a global level, and then focus on the United States. And I'll focus a little more on New York City, although I don't work in New York City anymore. I'll just say a few things about it because it's a place where there's still a fair amount of TB, and it represents, I think, some aspects of TB in the United States that are applicable to other parts of the country. It should take me, I don't know, 35 or so minutes to get through this, and then I hope there'll be plenty of time for questions. So that timing sounds okay, Anita?
Sounds great.
Okay.
And we can go until, we had sort of increased the time frame a little. We can go until 11:15, depending on how many questions we have.
Okay. Okay. You can see that? It says Overview of Global National TB Epi. You see that slide?
Yes. Can you make it slideshow? Perfect.
Looks good. Okay. So with that, we begin. So the most recent data we have on international level come from the most recent World Health Organization Global Tuberculosis Report, and that reports data through 2022. And this map shows you incidence rate of tuberculosis in all countries in the world as WHO understands it in 2022. I'll come back to this in a second, but overall, the estimate is that there are about 10.6, so just over 10.5 million new cases of active tuberculosis disease in the world every year, and about 1.5 million deaths. Now, this map shows you incidence rates, that is new cases per 100,000 population in all countries in the world. And you see that there's sort of a familiar west to east, north to south gradient of increasing tuberculosis incidence in the various countries in the world. I'll point out just a few notable places. So here in the United States, we'll talk quite a bit about the US in a few minutes, but you can see the US is very lightly colored along with Canada, most of Western Europe, Australia, and New Zealand. The TB case rate in the US is on the order of about 2.5 or 2.6 cases of active TB per 100,000 population. Now, 45% of all tuberculosis cases in the world come from just 3 countries, China, India, and Indonesia. And you can see the incidence rates in those countries is quite a bit higher than it is in the US. And ranges, I would say, in China, India, and Indonesia from about 100 to maybe as high as 250 cases per 100,000. So the US 2.6, China, India, and Indonesia somewhere between 100 and 250 per 100,000. And then you go to sub-Saharan Africa, we have some of the highest rates of TB in the world, particularly in South Africa, where the rate of active TB approaches 1,000 per 100,000. So 2.6 in the US, 100 to 250 in India, China, and Indonesia, and 1,000 per 100,000 in South Africa. Now, think about that for a second. 1,000 per 100,000 is 1%. That means that 1% of the population of South Africa at any given time has active tuberculosis. And I've seen very recent epidemiologic data that's being collected for research purposes that seems to confirm that that is in fact true. So that's the incidence of TB in the world. You can see there are other places where TB is common. As mentioned, most of sub-Saharan Africa has very high rates of TB. Most of South and Southeast Asia has very high rates of TB. Here's North Korea with a very high rate of TB, and much higher than South Korea, although South Korea has a higher rate of TB than most other wealthy countries in the world, which is sort of interesting. But that's an overview of the global burden of TB from sort of the 35,000 foot view. Now, how are we doing in terms of TB cases in the world? And the answer is not very well at all. On the left, I'm just showing you the sheer number of TB cases in the world every year. On the right, I'm showing you the rate. So cases per 100,000 population. So on the left here, at the top in blue, you can see that for the last 22 years at least, the sheer number of cases of TB in the world really has not gone down at all. The rate of TB, number of cases per 100,000, has gone down. Why? Because the population of the world is growing. The denominator is getting bigger, but the numerator, the number of cases of TB in the world every year, is not going down. The number of cases in HIV-infected persons has gone down quite a bit. In a sense, that means the number of cases in HIV non-infected persons has gone up. So I think this is very sobering and should really make us ask ourselves many questions. This is in still most cases a completely curable disease, one of the leading killers in the world, as I'll show you in a moment. But we are making almost no progress in reducing the number of cases of TB in the world over a long period of time, a 25-year period of time. Now, in terms of TB deaths, we do seem to have been making some progress again over the last 22 years or so. The total number of TB deaths declined from about 2.2 million or so back in the year 2000 to about 1.5 million. In the last couple of years, this is felt to be mostly because of the negative impact of COVID on the ability of tuberculosis control programs to function. There's been an uptick in TB deaths around the world. And so the absolute number of TB deaths went down, a little uptick in the last few years. The same is true for the death rate for tuberculosis. Again, because of the tremendous improvements in the treatment of HIV infection, not only has the number of cases of TB and HIV infected persons declined, but the number of deaths, related to tuberculosis in HIV infected persons globally has also declined. So some improvement in death from TB, almost no improvement in the overall burden of active TB in the world. Now, I showed you where people get TB in the world. Here I'm showing you a little bit more about who those people are with tuberculosis by age group. And I think this is something to really keep in mind. It's very important. The mode of the distribution of persons with TB, that is to say, if you just group people by age in broad categories, most people with active TB in the world are between the ages of 25 and 44, and that's true for women and that's true for men. We think sometimes that TB is a disease of older persons, and it's true that older persons and very young persons, particularly children under the age of 5 years, it's true that people at those extremes of age are very vulnerable to TB, but they represent a smaller part of the population. So the mode of the distribution of active TB cases incident active TB cases in the world every year is really in the 25 to 44 age group. It's a disease of young people. And so the consequences of that are really enormous. When people get bad TB, they might have to be hospitalized or be out of the workforce for a prolonged period of time. So the economic impact of TB is magnified by the fact that it's basically young people who get TB. And then I'm not really going to talk about this today, but we realize now that many people who get TB, even if they're cured, wind up with very substantial destruction of lung tissue and turn what was an infectious disease into a very bad chronic lung disease because of all the scarring and lung destruction that occurs often as a result of TB. So the fact that TB is mostly a disease of younger populations really creates a situation where tuberculosis contributes ultimately to a very substantial burden of chronic lung disease that begins relatively early in life. We think of, in the US, chronic lung disease mostly as being things like chronic obstructive pulmonary disease, COPD, or asthma. But if you look on a worldwide scale, a very significant percentage of chronic lung disease is just post-tuberculosis destruction and scarring that happened when people were relatively young. So that's why this age distribution, I think, is important. Now, I mentioned before that there's been some progress in reducing TB deaths, but TB still remains a very important cause of death in the world, and that's shown here in this figure from the most recent WHO Global TB report. You can see TB looks like it's sort of far down on the list. Ischemic heart disease everywhere in the world, is the leading cause of death. And then you have stroke and COPD. So TB looks like, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13th leading cause of death in the world. And that's still pretty high for a disease that's really easy to diagnose and completely treatable. But if you look here, the gray bar, this is the number of people who die of tuberculosis who have HIV co-infection. And for many years, if you have HIV, but you die of TB, that's counted as a death from HIV and not a death from TB. If you counted that as a death from TB, you could see that TB moves way up on the list and would be 1, 2, 3, 4, 5, 6, 7, 8, 9, would be within the top 10 leading causes of death in the world. But any way you slice it, the morbidity and mortality due to tuberculosis on a global scale is just enormous. And really, as I said, somewhat shocking if you think about the fact that TB, as I mentioned, is generally easy to diagnose and curable in almost every case. We'll say a little bit about the exceptions later. Now, what about HIV as a driver of tuberculosis? This is the HIV prevalence among new cases of TB in the world. Again, the most recent data we have from WHO. And what you see here is interesting. HIV has been the driver of the TB epidemic in sub-Saharan Africa for a long time. And you can see here that in many countries in sub-Saharan Africa, HIV is present in 20 to 50% of all persons diagnosed with TB, and even more than that in South Africa and some neighboring countries. So HIV has really been the driver of the TB epidemic in sub-Saharan Africa. There are other countries, Brazil here is a notable example, Mexico, Russia. This is Ukraine right here under Belarus. So there are other parts of the world where HIV infection does contribute very substantially to the TB epidemic. But then you have other very high burden countries for TB where HIV does not seem to be driving the epidemic. And two of those countries, very importantly, would be China and India, where the rate of HIV co-infection is quite low, comparable to what it is really in the United States. So sub-Saharan Africa, Russia, Ukraine, Brazil, Mexico, places like that, HIV still is a major problem, but other parts of the world where TB is quite common, in East Asia, South Asia, and other parts of Southeast Asia, HIV infection is not driving the epidemic. What about the emergence of tuberculosis strains that are resistant to rifampin or rifampin plus isoniazid? So we call multidrug-resistant tuberculosis that's resistant both to isoniazid and rifampin, at least to isoniazid and rifampin, but even rifampin monoresistance creates significant challenges in the treatment of TB. So we tend to lump in the rifampin monoresistant cases with the multidrug-resistant cases, as I said, resistant to both at least isoniazid and rifampin. So about 500,000 cases of this in the world. I'll show you in a moment why this is a particular problem. Now, the epidemiology of this has been quite interesting because one of the first places multidrug-resistant tuberculosis was really recognized as an important public health problem was in New York in the late 80s and early 90s. I was starting out my career then at Bellevue Hospital in New York, and in 1992, about 13% of all the TB in New York City at that time was due to multidrug-resistant strains. For a variety of reasons, that's gone away, but it led WHO to do global surveys and really look for these cases, and the data were really shocking. What you see here is that there are a lot of countries in the world now that have reasonable amounts of multidrug-resistant TB, but the places where this is really a completely out of control problem is in Russia and countries of the former Soviet Union. So again, here you have Russia at the top. You have the Baltic states here, Latvia, Lithuania, and Estonia, and then Belarus, Ukraine, Kazakhstan here. Mongolia is a little less than Kazakhstan and the Soviet Union, but a lot there, and several of the other Central Asian countries. So Russia and the countries of the former Soviet Union are places where 20 to 50% of all cases of TB are caused by multidrug-resistant strains, and that's really worrisome. Now, you do have in China somewhere between 3 and 6% of TB cases are multidrug-resistant cases, and that's true in Korea here and Japan. But China is an enormous country with a lot of TB, so even though the percentage of MDR cases is relatively low compared to, let's say, Russia and the countries of the former Soviet Union, the sheer number of TB cases in China with multi-drug resistance is high, and China contributes a lot globally to MDR TB cases. Same is true in countries of Southern Africa as well. Now, why is this such a big problem? You can see that data from WHO suggests, as I mentioned before, that although there are 500,000 people with multi-drug-resistant TB in the world, fewer than half of those persons are ever diagnosed or started on treatment. And if they are started on treatment, treatment outcomes are satisfactory in no more than half of those cases. So you have about 500,000 people in the world with multi-drug-resistant TB. Most of them are not being treated or diagnosed. So what that means is they're at very high risk of dying. But before they die, there's a very good chance that they will spread those multi-drug resistant strains to other people. So this is, I think, a sort of still out of control public health problem in the world, multi-drug resistant TB, and something to really be concerned about. We'll come back to this in the US context in a little bit. In the US, this is not a major problem at all. So if you look at TB overall, or TB HIV and multi-drug resistant TB, this is sort of a graph that WHO has come up with to show you the countries that are high burden in all of these regions. So if you're in a country that's surrounded by red, those are the overall just high burden TB countries. So all the countries in this box, and down here in Sierra Leone are the high burden TB countries overall. The countries in yellow are countries with a high burden of TB HIV. So there are lots of overall high burden countries that have huge numbers of TB generally, and they have huge numbers of persons co-infected with HIV. So those are all the countries in the yellow box. And then the blue box are countries with high rates of multidrug-resistant TB. And you can see, so some of those MDR countries are also in the red boxes, and so that means they have a lot of TB to begin with, and some of them are in the yellow boxes. So this right here, this group of countries where you're surrounded by blue, red, and yellow lines, these are countries that have high rates of TB, high rates of HIV, high numbers of TB patients, high numbers of HIV infected persons, and high numbers of people with MDRTB. So these are countries with really sort of a triple whammy of TB, HIV associated TB, and MDRTB. Okay. All right, so let's transition a bit and talk about tuberculosis in the United States. This graph from CDC goes all the way back to 1982, so 40 years ago, and you can see that there's been a trend for at least the last 30 years of almost complete and steady decline of TB cases. Cases back in 1982 were about 25,000 cases of TB in the US. It had been going down for a long time, but that decline stopped in the late to mid 80s, partially because of HIV, partially because of many other factors, and cases began to rise to a recent peak in 1992, when there were over 26,000 cases of TB in the US and a rate of 10.4. A lot of things have happened. That's kind of another talk for another day. But TB rates since 1992 were declining very steadily. We're declining very steadily and reached really a low in 2020, 2021, where the incidence rate of TB in the United States fell to about 2.4 per 100,000, really about the lowest rate of TB in the world, and fewer than 8,000 cases of TB in the entire United States. I mean, TB really has become a rare disease in the United States. Again, we're talking about active tuberculosis. Here I'm just showing you the last few years blown up a little bit. This is the most recent CDC data released in March 2023. Because it shows something interesting. So there was this, long, steady decline. And then there was a very sharp decline from 2019 to 2020. You can see that here. That was probably due to the fact that because of COVID, lots of clinics closed and many fewer people went to see doctors. And so I think what everyone thinks is that TB cases didn't drop that precipitously from 2019 to 2020, but probably people were just less likely to be diagnosed because they were unwilling or unable to get to functioning TB clinics in the US. So in the last 2 years, in 2021 and 2022, there's been an increase in reported TB cases to the United States. They're still below 2019 levels. But it's going to be interesting to see where this rise of the last 2 or 3 years settles in. When the question sort of being in 2020, when people stopped getting their TB diagnosed, if we really think that was because people didn't have access to services, there might have been a little bit more TB transmission in the community, and we might see more TB cases. As a result of that, we're just going to have to see. So cases still overall in the US are at historical lows. The incidence rate, about 2.5 per 100,000 overall. But we'll just have to keep an eye on this recent trend. HIV co-infection in the United States is, on the whole, relatively uncommon. You can see for all age groups, only about 5% of persons with TB in the United States are HIV co-infected, a little higher in younger age groups with TB, but even in those age groups, it's sort of in the 6 to 8% range. So the United States, by and large, is not a country where HIV is driving the TB cases that we see here. What about multi-drug resistant TB? As I mentioned, back in the early 90s in New York City, this was a major problem where we had about 13% of our TB cases were due to multidrug-resistant TB. But this has really dropped off very, very dramatically in the United States. And you can see the orange trend line shows you that among persons never previously treated for TB in the United States, only about 1% of those cases are due to multi-drug-resistant strains. So, and that's been really true for a number of years. There's been this very sharp decline in multi-drug-resistant TB. I think this is because we're lucky in the US in general to have very good local TB control programs, and patients are treated appropriately and given good care. So this is a problem that in the US at least is, I think, very much under control. This shows you really what we're talking about, the annual change in rate of TB. This very sharp drop in TB rates from 2019 to 1920, and then an increase from 20 to 21, and another little increase since then. And as I mentioned, we'll just have to keep an eye on where that goes. Death from tuberculosis in the United States, about 600 TB-related deaths per year. That's about 9%. 8 or 9%, which is, higher than you might think for a disease that's completely, an infectious disease that's completely treatable, and one in which patients don't tend to present with what looks to be life-threatening illness. So TB, although it's uncommon in the United States, still does seem to carry a significant mortality risk of about 8 or 9%, so something to keep in mind. Now, where are TB cases occurring in the United States? This is very interesting. On the left, these are data from 2021. 2022 data look about the same. On the left, you can see that 4 states, New York, Florida, Texas, and California, account for half of all TB cases in the whole country. So New York contributes 9% of all the country's TB cases, Florida 6%, Texas 13%, California 22%. The rate, okay, it's a little better. The rate of TB in some of those states and major cities in the United States is shown on the right. So this is New York State overall. New York City has a higher rate than 3.4, but New York State overall has a rate of 3.4, which is higher than the national average. New Jersey similarly has a rate that's slightly higher than the national average. Delaware, Maryland, DC is right about the national average. Texas, again, over the national average. Hawaii and Alaska have rates that are 2 or 3 times the national average. California, higher than the national average. So these are parts of the US that have higher than the national average rate of TB, and really all of the darker purple states are states where that is true. But interesting, as I said, to reflect on the fact that just 4 states, New York, Florida, Texas, and California, contribute half of all cases of TB. This is, I think you'll have separate lectures on most of this. Most TB in the United States is pulmonary TB, 79%. 21% is extrapulmonary TB. Okay, now on an individual level, who's getting TB? I showed you by where people live. Who are those folks? So on the left, TB cases by race and ethnicity in the US for the last several years. You can see Asian persons account for 36% of all TB cases, followed by Hispanic or Latino patients, 31%, Black or African American, 18%, 11% white. And that's been pretty steady for as a distribution for the last several years, I would say. So TB in the US does represent a disease mostly of racial or ethnic minority groups. Like the rest of the world, most TB in the United States does occur in the 25 to 44 age group. So there are a lot of cases in people in those age groups, and that again has been true for a long time here. Although the decline in TB cases in the U.S., you can see, has very substantially been in the 25 to 44 age group. So you can see here, that's this sort of light green color. That as a number and as a percentage of the total, I think, has declined over the past 30 years or so. And so there's percentage-wise, there are maybe a few more cases in older age groups in the United States. Sorry, I don't know why it keeps going back. And that's sort of shown here. If you look at the TB incidence rates, right, again, because of the demographic makeup of the US, how many older versus younger people do we have? It's a little different than it is in lower middle income countries, which tend to have much younger populations. We have a somewhat older population in the US. So the incidence rate of TB is highest in the greater than 65 age group, but the total number of contributed cases is still in younger age groups in the US. Okay. Now, what about other risk factors? We talk about risk factors for TB. We mentioned HIV infection a little while ago, which on a global scale is one of the most important risk factors for TB. But what about other risk factors that we typically associate with tuberculosis? Here are some of them. Excess alcohol use, present in 8% of TB patients in the US, non-injecting drug use in 7%, 5% are homeless, 2% in correctional facilities, 2% in long-term care facilities, and 1% drug use. These numbers, my guess, are lower than what you would expect to see. I think when a lot of us were growing up and learning about TB, we learned that all of these things were related to TB in one way or the other. I'll come back to the reason why I think these numbers are a little less than what you might expect to see for risk factors in TB. And I just want to hone in a little more detail on correctional facilities, right? We're always worried about TB in prisons and jails, but only 2% of people with tuberculosis in the United States have had a history of incarceration in a correctional facility. It had been as high as 5% at some points in the last 30 years, but there's a pretty steady trend line down. And at the moment, as you see here, only about 2.25% of all persons with TB in the United States have had a history of being incarcerated in prison or jail. What about occupations? This is meant to be reassuring, this slide. 21% of TB patients are unemployed, 20% are retired, 15% are not seeking employment. So a lot of people aren't working. Healthcare workers, 4% of TB patients in the United States is healthcare workers. And I don't have time to go into this in a huge amount of detail, but being a healthcare worker in the United States now does not really put you at increased risk for getting TB. In decades past, healthcare workers, particularly nurses, because let's face it, nurses really are the ones taking care of the patients all the time. Nurses had a very high risk of contracting TB, but TB is now so uncommon in the United States that unless really all you do all day long is work as a TB physician or nurse, you're really at very little increased risk of contracting TB as an occupational hazard if you're a physician or a nurse just working in a general clinic or a general hospital. And that's really what I'm showing you here. Now, there is one really important aspect of TB epidemiology that's occurred in the US over the last 30 years, and that's shown here. And that is, so as I've shown you that, TB really is not a disease in this country associated so much anymore with things like homelessness, alcohol abuse, injection drug use, HIV infection. What is it associated with? Well, one of the things it's associated with is birthplace outside the US, and that's shown here. So in 1993, when the United States had 25 or 26,000 cases of TB, 2/3 or more of those cases occurred in persons born in the United States. Okay, so 30 years ago, TB was a disease that was occurring mostly in persons born in the US. And if you looked at who those people were back 30 years ago, those were people who had HIV infection, people who were homeless, people who were injecting intravenous drugs, people who were alcohol users, and people who had a history of incarceration. But if you look now in the United States, the country as a whole, 70%, only 30% of patients with TB in the US were born in the United States, and 70% of them were born outside the United States. Okay. Now, the rate of TB occurring in persons born in the US is still much lower than the rate occurring in persons born outside the US. In the United States, we have about 350 million people. About 44 million of those people were born outside the US. If you take that 44 million as a group, their rate of TB is about 12 per 100,000. That's still a pretty low rate. I mean, that would put you among the countries in the world with the lowest rate of TB, as I showed you on the very first slide. Of the 310 million Americans who were born in this country, the rate of TB is only about 0.8 per 100,000. Okay. But since, yeah, okay. Now, where are TB, what countries among persons who are born outside the US who develop TB in the United States, what countries do they come from? It shows you the leading countries in the world contributing TB cases to the US as a whole in 2021, Mexico, India, Vietnam, Philippines, and China. And this is a very important slide, actually, that says how long are people in the United States before they develop TB? And I think, again, this is a big surprise, because you might think that people develop TB very soon after they come to the United States, because we're always taught, and I'm sure this will be reviewed in other lectures in the course, we're always taught that your risk for TB is highest in the first year or two after you've been exposed. And that might make you think that, okay, someone is coming here from India, that let's assume they were exposed to a TB case very soon before they left, they should develop TB within the first year or so. But you can see that it's only 10% of people who developed active TB within the first year of arrival in the United States, and only 25% of people develop that within the first 5 years. So 75% of non-US born persons who will eventually develop TB in this country develop that TB after they've been here for 5 years. So from a public health standpoint, that means if you think you should be targeting the non-US born for testing of latent TB and treatment of latent TB, you can't just say, okay, I'm going to take the people who just arrived or arrived within the last 5 years. You'll miss most of the non-US born population at risk for developing TB. Now, everything I've said about the US is true for New York City as a whole. I'll just leave you with this one local example. This just shows you TB cases in New York, 536 cases in 2022. I worked at Bellevue Hospital in 1992. We had 500 cases of TB just in Bellevue Hospital in 1992, and now there are only 536 in the whole city. That's a rate of 6.1 per 100,000. That's very low. In New York City, it looks like the US as a whole, but even more so, 85% of TB cases in New York occur in persons born outside the United States. The countries represented are a little different than they are from the US as a whole. China leads 134 cases of TB in New York last year from persons who were born in China. Ecuador, Bangladesh, the Philippines, but then lots of other countries. This just represents patterns of immigration to the New York area. Now, I want to say one final thing about TB in the non-US born community. For many years, anytime someone gets TB in the United States, that TB strain is isolated and genotyped, and we can compare it to other TB strains in the United States to see if there's ongoing transmission in the community. So I have a DNA fingerprint I make from one strain. I compare it to all the other DNA fingerprints from everybody else with TB in this country, and I see if there's a match. If there's a match, I assume there's been recent transmission. So CDC has been doing this for a long time, and if you look at just the years 2020 and 2021, 88% of TB cases in the United States were felt not to be related to recent transmission, and only 12% are related to recent transmission. And most of that and very few of that recent transmission is extensive, meaning more than 6 or 8 cases, more than 6 cases in a cluster. So very little TB is being transmitted in communities in the United States, and that's particularly true within the non-US born community. There's very, very little transmission going on in the immigrant communities in the United States where TB is occurring. I often say in that community, TB in a sense is a non-infectious infectious disease. What I mean by that is TB in the non-US born is almost always the result of just reactivation of latent infection and not because of community spread. There is much more community spread of TB cases among the US born population in the United States, although the total number of cases in that population is much lower. So with that, I'll just sum up and say that TB incidence rates have declined only very gradually in the country over the past 20 years. The COVID pandemic set back TB control efforts sharply around the world and in the United States. And so we'll have to see over the next few years if that's had an effect on the overall burden of TB. Mortality rates from TB have gone down, although even in the US, about 8 or 9% of people with TB will die. But otherwise, TB rates in the US are at historic lows. And non-US born persons account for the majority of cases of active TB in the US. And almost all cases in that segment of the population are due to reactivation of latent infection and not community transmission. So with that, I will end and stop sharing and have some time for questions.
Great. Sorry. Thank you, Dr. Schluker. That was such a great talk. I mean, it's really an important talk to have too, because when you're talking to the community or you're assessing patients, you really want to know, their country of birth and what's the incidence rate in that country or MDR rate in that country, to maybe look for red flags when you're thinking, possible MDR. But we do have some questions, and I'm going to get to the first one, and that is, what is the recommendation? This is a good question. What is the recommendation for treating latent TB in patients who are native of multi-drug-resistant countries?
Right. So that's a great question. So if you saw someone who was recently arrived from, let's say, Russia or Belarus or Ukraine or Kazakhstan or any of those places where there's a lot of drug-resistant TB, it's still more likely that someone with latent TB in that country has drug-susceptible TB. It's still more likely, even if 25% of all people in those countries have MDRTB, that means that 75% don't. So anybody with latent TB is still a little more likely to have been exposed to a drug-susceptible case than a drug-resistant case. So in general, if I just saw sort of an undifferentiated person coming to the US from Kazakhstan, a country I've been to and done some work on the epidemiology of TB in Kazakhstan, if they had latent TB and I wanted to treat them, I would treat them with one of the standard regimens we use for treating latent TB as if they had latent TB from a drug-susceptible strain. So my personal favorite way to treat latent TB is once a week isoniazid and rifampin for 12 weeks, or once a day rifampin for 4 weeks, and I would do that. When would I not do that? If someone told me, yeah, I lived with, my brother, my cousin, my sister, my wife, whoever it was, and they had TB and it was multi-drug resistant, they had to take medicine for, 2 years, then I might think about doing something else. The problem is we don't know what else to do. There are no clinical trials to show effectiveness of treatment of latent multi-drug resistant TB. So I think, absent a very specific history of high risk exposure, I would just treat the person as if they had latent TB from a drug susceptible strain.
Great, that was a good question. I do have another question. To what do you attribute the high 9% mortality rate for TB in the US?
Rajita, how are you? It's nice to see that question. Yeah, that's a really good question. I think that probably represents in the US two things. Those cases really are almost always occurring in older persons with TB. So I think, you know, that may just be it. But I think, you know, often we still see cases of advanced TB where people don't come to medical attention for a long time. There's still some people who are resistant to take TB medicine. So I don't think there's one single answer, but I think most of that is occurring in much older patients with TB.
And let's see. Do you think that 20% of cases among retired persons may be attributed to older age, or perhaps folks who are doing more travel to TB endemic areas?
Right. So again, remember that the vast majority of TB in the U.S. is occurring in non-U.S. born persons. So that 20% retired, you know, most of those people are retired people who came from somewhere else. But you raise a really interesting point there. You know, I mentioned at the beginning, and I think there'll be a whole nother lecture about this, I assume somewhere in the course, that, you know, we think that most people who reactivate latent TB do that within the first year or two. So how does it make sense that you've been here, you know, long enough to be retired and now you're getting TB? So this question always comes up. You know, is it in fact because people are going back and forth and traveling to high burden countries and getting reinfected? And so I think there's a pretty good chance that that must be playing a role. You know, everybody travels. I love to travel. You know, we live in a world where a lot of people travel. But if you come from somewhere, you know, you come from India or China or wherever you come from, you know, you go see your relatives and your family. And so we say, oh yeah, you've been in the US for 20 years, but in reality, you know, you're spending 6 weeks back home every year or so. And so that might very well be the reason that there's return travel.
Thank you. If anybody else has any questions, feel free right now to either unmute or put it in the chat. I do have another question. If serum quantiferon level is the gold standard, why do we continue to do skin testing?
Okay, so again, I assume in the lecture on diagnosis and treatment of latent TB, this is going to be discussed a lot, but that's a field I've worked in quite a bit and published a lot of papers about quantiferon and things like that. And I think the CDC recommendations for testing for latent TB and using interferon gamma release assays were issued in 2010. I don't believe they've been revised since then because I think the recommendations still make sense. Conflict of interest or fair warning. I was the chairman of the expert panel that wrote those recommendations, and we said that you could use either test anytime you wanted, but in particular in persons born outside the United States, quantiferon was preferred because there's less concern about false positive results in people who've had BCG vaccine. Okay, so I think it makes complete sense, especially in non-US born persons, to just test them with quantiferon and not do skin testing. Now, two little side notes to that. There is now, there has been the development of skin testing using, instead of PPD, using only the antigens essentially that are in the quantiferon test, which return the specificity of that test, even in people who've had BCG. You're still left with the hassle of doing skin testing, but okay. And I think quantiferon is just much easier. It's just a blood test and you get a number. The one caveat there is that we did an experiment, pretty rigorous one, in healthcare workers where we tested everybody every 6 months with skin tests, quantiferon, and then TB spot, TB, which is another commercially available IGRA. And if you test people every 6 months, you seem to get a lot of false positive results with quantiferon. So as much as it pains me to say this, because in general, I'm a great believer in interferon gamma release assays and quantiferon, I think in the clinic, for the average patient you're seeing, they make a lot of sense, and that's what I would do. For healthcare workers who are going to be tested very often, I would still do skin testing to avoid the false positives. And again, I think you're going to have a whole talk about this. But the reality is most healthcare workers don't need to be tested every year. So I'll save that for whoever is going to lecture about that. So.
And that'll be next week, testing for LTBI, or next week's in the series. But I also maybe sometimes it could be cost, depending on the clinic and
Right,
that
skin testing is still the cheapest.
Yeah.
There's nothing wrong with doing skin testing, but you should know that if you do it in non-US born persons, foreign-born persons, you'll get some false positive tests in BCG. And then I see this question from Amanda Crawford. The answer to your question is yes. Like a skin test, a quantiferon gold will stay positive forever. That's because all of these tests, skin tests and interferon gamma release assays tests, are not testing for the bacteria. They're testing for your immune response to the bacteria, and your memory T cells stay around for your whole life.
Then I have a little off topic, but since underdiagnosis of TB was mentioned at the global level, can you comment on whether new point of service tests, AI can be of assistance, just even just for frontline screening?
Yeah, so it's a great question. And in places where TB is very common, there's a lot of implementation science research that's being done around the world using TB Ultra, which is sort of a handheld version of Gene Expert, the nucleic acid amplification test now that we all have either in our hospitals or in the county lab, where the Gene Expert machine. So there are now sort of handheld versions of that. And they are being used in implementation science studies to see if we should just be doing aggressive active case finding in places where TB is very common. So in the United States, I don't think this is ever going to be an issue. TB is so uncommon here that it doesn't really make sense to do active case finding. But in places where TB is very common, I think doing that might make a lot of sense. And there's been some really exciting research about that.
Thank you. And then what are risk factors of chronic illness with TB?
So I think you'll get that again in the lecture on latent TB, but HIV infection is still the most important. But I think that the two that we've recognized in the last, I would say 15 to 20 years as being really more important than we had realized. One is cigarette smoking. Cigarette smoking is a significant risk for going from latent to active TB, and poorly controlled diabetes, which is an epidemic not only in wealthy countries like the United States, but more and more in poorer countries around the world as well. And then you have all the sort of the other big one in the United States and many other countries now too is people taking immunosuppressive medicine. Right, all those things you see advertised on television, Humira, ask your doctor, could increase your risk of TB. There's a lot of medicines like that now that we use to treat all sorts of complicated rheumatic diseases. People have had organ transplants and things like that.
Thank you. I'm not sure if this is this actually a question for you or just in general, but I guess it's, will you talk about TB testing for people who come to the US? We are going to be talking about TB testing next week. Ideally, we'd assess when they arrive, and in 8 weeks, cost is an issue. Do you recommend IGRA and when they arrive, and then just do a symptom assessment in 8 weeks?
Right. So I think the 8 weeks, I don't want to say too much about this because I think I'll have a lecture about that. I think the 8 weeks there is coming from what we do sometimes in people who are close contacts of active cases. And their test is negative, and we retest them 8 weeks later because we think they might be in the window period. That's not something I would generally do for just the average person coming to the United States from a foreign country. I would just test them once, and that's it.
Great, great. Last chance to put in your questions while we have our fantastic speaker here with us today who can answer them. If not, there's just one reminder I want to get out there before we close for the day, that at 12 o'clock today is Grand Rounds, and it's going to be TB in critically ill patients, which I think that's going to be a fantastic topic. And now it is in, is that the link there for the TB Grand Rounds? Oh, no, that's for the evaluation. I don't know, Shweta, if you have a link for the Grand Rounds, if you could put it in the chat, that would be great. There is also a link to the evaluation in the chat. And Dr. Schluger, have a great weekend. Thank you so much for doing this. It was excellent. And we are so happy that you were able to take time out of your very busy schedule to join us today.
Always my pleasure. I'm a big fan of the New Jersey TB Center. Lots of friends there, and it's great to see you all even indirectly, and Everybody have a glorious 4th of July.
You too.
Bye-bye.
Thanks again, Neil. Bye,
Bye-bye.
everyone.
See ya.